To going straight to the topic, the fundamental aims of doing a TURBT is to resect all macroscopically visible lesions and get adequate tissue for a histopathological diagnosis. And in a urothelial carcinoma, especially in non-muscle invasive bladder tumor, it would be the treatment for the cancer. And so to get a complete treatment for non-muscle invasive bladder cancer, you need to have a complete and optimal TURBT, which has detrusor muscle in the specimen. The bladder tumors can be serviced by using a monopolar current or bipolar current, and currently lasers also have been adopted in TURBT. Till recently, gold standard has been TURBT. It's been taught by all training centers. All residents learn this easily during the training program, and it withstood the test of time. It's been done for over 60 years now. And the methods of doing a TURBT using monopolar is either a piecemeal using a standard chip resection, or over the last 10 years, we have evolved in doing what is called the en bloc resection. And this could be achieved by using monopolar current or even a bipolar current. So today I'll be running through a couple of videos on using monopolar strategy for doing TURBT. The energy settings that we use depends on the machine. Different machines have different energy settings. The standard machine that we use is the Valley Lab, the Force FX. We tend to use a current that is lesser than used for standard TURP. I would prefer to work between 90 to 100 watts of pure cut and 80 watts for coagulation. Sometimes you need to step down a little bit and go a little lesser for fear of perforation, especially in patients who are undergoing a re-TURBT where the bladder wound is recurrent at the same site. We would tend to use thin loops when the lesion is small, where you want to take out the chips in small, precise cuts. And if the tumor is large and vascular, you could use a thick loop or a new loop for doing the resection. So what I would do is I would run through a few videos on how I do it. This would be a 65-year-old male who had a tumor on the left lateral wall. And this is the large tumor. And we have used monopolar current for this patient. And all these patients undergo an obturator block in our sitting. Just because one has used an obturator block, that doesn't prevent the jerk happening. So you can see this is a chip resection that we do. We go on doing systematically from one side, and we try not to over distend the bladder when we do the resection. So the resection is always done using a continuous flow resectoscope. And we should be careful that we don't over distend when we resect, because a distended bladder tends to be thin, especially when you're doing a lateral wall resection. You tend to perforate if you're over distending the bladder. So you can see that the resection is in process and systematically chips. If the stalk is small, you can do a retrograde cut. It's easier to take out a small stalk tumor with a retrograde cut, but systematically it's done using multiple chips. Now we watch this carefully. That's a jerk that has happened. This is in spite of us using an obturator block. You see the starting of the loop was dug a little deeper and there was a jerk. Fortunately, there was no perforation when we did this case, and we could complete the resection adequately with taking a deep biopsy. It's mandatory that once you do the TURBT with monopolar, all the chips are removed and subsequently another chip is taken which involves the muscle. If it's a broad-based tumor, you would want to take the deeper muscle at multiple points so that you ensure that the staging is adequately represented in the specimen. This is another patient who had multiple tumors. You can see he has tumors on the right lateral wall. He had tumors at the posterior wall, but they were all frondy and appeared superficial. And what I would do is normally I would take out tumors that are easier to resect, especially the ones on the trigone and posterior wall. It doesn't cause too much of a problem and you can resect them easily. Then try to go up to the tumors on the lateral walls. If there's a tumor in the dome and anterior wall, I would approach them last so that I finish the easier tumors early. So this patient had multiple tumors. They all looked superficial and frondy. We were able to resect all of them in one go. And all of them, we are seeing that we are doing a simple chip resection. Multiple bits are being taken. The chip resection can start from one side of the tumor to finish the complete side. Sometimes you have very large protuberant tumors, and then you might want to flatten these tumors out before you could take them out completely. So systematically from one side to other, the tumors are being removed. Another way of doing these is sometimes you find that these blood vessels are very prominent around the base of the tumor. You could fulgurate the base of the tumor before you remove the tumor itself. You don't allow too much of bleeding to occur. You go on coagulating as you go on resecting. This is a vaporotode that we found it very useful. When you have a large base in the tumor, at the end of the resection, after taking a deep biopsy, it works well to to coagulate the base of the tumor and get adequate hemostasis. This is manufactured by a company in Mysore. I think even stores makes this kind of electrode. It's very good to vaporize the base of the tumor to coagulate the base of the tumor. This is another patient who had small bilateral, two tumors on the left lateral wall. And in this patient, we deliberately chose a thin loop. And this is a video which was lent to me by my friend, Dr. Manish Sinha. And you can see the loop is thin and the resection is very precise, short movements. And we were able to complete the resection with this. The first case I showed you, it was a new loop and loops are much thicker. And this is a thin loop which makes very precise shortcuts. So we'll move on a little quicker. So we were able to resect both tumors completely, get good hemostasis, and take deep tissues subsequently. Besides doing the chip resection, we also have what is called the enucleation or en masse resection. And this could be done by either using a loop electrode or a hook electrode. This is a clipping in a patient who has undergone an en bloc resection using a hook electrode. The tumor base is circumcised completely all round, and slowly it is lifted off. You need to go till you see the detrusor muscle, and the detrusor muscle is dissected off completely all round, and the tumor is enucleated en masse. The advantages of this is it's good for the pathologist to examine the total tumor and give a proper histological picture of the specimen. There is not much of cautery artifacts when you do an en bloc tumor, and currently for small tumors, up to 2.5 to 3 centimeters, it is advisable to do an en bloc resection because the quality of the specimen is good. There's still data to emerge whether it makes any difference in the overall outcome in terms of completeness of resection or in terms of recurrence. But the specimen on histopathological examination is a better representation, and you can almost get a complete clearance of a non-muscle invasive tumor in this. So you can see the adequate detrusor in the specimen, which is enucleated. That's the specimen, and you just need to coagulate the base of the tumor. There's going to be a lot of debate during the session, current versus bipolar current for your TURBTs. All the possible combinations have been reported. The complications with the TURBT with either monopolar or TURBT or bipolar has been reported in numerous meta-analysis and review. There is no difference in outcome. In fact, there are a lot of papers which says that the obturator jerks are more when you do a bipolar TUR rather than a monopolar TURP. So to us, it doesn't make any difference whether to use a monopolar or bipolar when you do the resection. There can be difficulties when you do a TURBT sometimes, and these are the reasons why you could have difficulty when you have multiple tumors, when there's a lot of bleeding, and tumor is in a difficult situation. And the complications occur during procedure and can make the TURBT difficult. So it's better to stop the procedure if it's very difficult and go back after a couple of days. You'll find the vision is much better. So a good quality TURBT using monopolar will involve complete resection of all the visible tumors, and it will there's a paper by EORTC which suggests that there's a low recurrence-free rate at the first follow-up cystoscopy. It all depends on the quality of your first TURBT and the presence of the detrusor muscle on the specimen, the first TURBT. If it's a good quality, then you'll have a low recurrence rate at the first follow-up cystoscopy. And this is more likely to achieve with a good experienced surgeon. So we do an operative checklist in all our TURBT specimens. It's all noted down in the document, a urethral assessment, a bladder assessment. the macroscopic appearance of the tumor, the number of tumors, its relation to the orifices, and we do a mapping as a diagram. And we also note any complications, checklist for everybody to have when a first TURBT is done, because you need to have these patients on follow-up. You need to know where the previous lesion was and whether they had any surgical complications during a first TURBT. So this checklist is good to have. And what I would like to conclude this talk by saying that whether you do it with a monopolar, bipolar, or laser, it is not it's not the machine that matters. It is the man behind the machine that makes the difference in the outcomes of TURBT. Thank you.